So hello dear students, welcome back to this rapid revision video of healthcare system in India. We'll be talking about all the things related to primary healthcare and giving a gist, providing you with the gist of healthcare delivery system in India. So what is primary healthcare? Primary healthcare is defined as essential healthcare which is based on practically, scientifically sound and socially acceptable methods and technology made universally accessible to individuals and families in the community through their full participation, okay, and at a cost that the community and country can afford. So basically, you just have to remember one thing. Primary healthcare means essential healthcare, okay, which has to be offered to each and everyone in the community at a cost that the community as well as the country can afford. So this concept of primary healthcare was adopted in the Alma-Ata Declaration, okay, in the Alma-Ata Declaration of 1978, okay, which was a conference which was held in Alma-Ata, Kazakhstan, where the concept of primary healthcare was adopted, okay. And this concept is based on 4 A's. What are those 4 A's? That these essential healthcare services or these basic healthcare services should be available to all, accessible to all. So those are 4 A's. That means these essential healthcare services, okay, these essential healthcare services relies on 4 A's. What are those 4 A's? Availability of healthcare services, okay, availability. The healthcare services should be available. If it's available to the rich, also to the poor, okay, availability of healthcare services, accessibility of healthcare services. Like if I say that go and get your children vaccinated to people residing in a rural area, and now the immunization center is kilometers away, will they ever go? No. So that is accessibility. Plus the services should be acceptable to the community. So they should accept the thing which is being offered, okay, and affordability. Affordability means now if there's a rural area where the couple is not, where the people are not getting their children vaccinated, okay, why? Because when they go to a center, they charge money for it, okay, that you'll have to pay so much to get your children vaccinated. They won't get it done. All right, so that is why primary healthcare relies on 4 A's, which is availability of healthcare services, accessibility of healthcare services, acceptability, and of course affordability, okay. So the 4 A's of primary healthcare are these. This is very, very important, everybody, okay, don't mess up. Then the concept of primary healthcare relies on elements, okay. It consists of different elements, okay. Like I said that primary healthcare is essential healthcare, okay. So what are we offering in this essential healthcare? What are these essential healthcare or basic healthcare services that are being offered, okay? So that you can make out from this letter element, okay, from this word element, okay. This is the mnemonic only of the essential healthcare services, okay, element. So what does E stands for, everybody? E stands for essential drugs. Almost there are 34 essential drugs which should be available at all the healthcare facilities, out of which paracetamol is the most essential, okay. What is it? Paracetamol is the most essential. Then what is L? L is prevention and control of, yeah, it is prevention and control of what? Locally endemic diseases. Now, if let's say Japanese encephalitis is endemic somewhere, okay, it's an endemic disease. So we should be able to prevent and control that. How? By ensuring that vaccination for Japanese encephalitis is always available. What is E again? E over here means education. Education, not primary, secondary class education. No, this is what? Health education. All right, this is important. M say you have maternal child health, and since we are talking about maternal child health, and of course the next one is family planning services, okay, maternal child health and family planning. What is the other E, which is again very important, okay? So this is EPI, expanded program of immunization. Now what has EPI become? Now EPI has become, everybody, UIP, okay, universal immunization program. So basically to to remember immunization, we've just put this as EPI. EPI was expanded program on immunization, okay, expanded program on immunization. And what has this become now, everybody? UIP. What is UIP? Universal, okay, universal immunization program. So this becomes what? immunization. Okay. N is what? Of course, nutritional health. Okay, nutrition. And T is treatment of common ailments. Okay, treatment of common ailments. That means treatment of diarrhea, fever should be available in all the health centers. Okay, so what are the essential components or elements? It's based on the mnemonic elements only. E stands for essential drugs, L stands for prevention and control of locally endemic disease. Okay, again E is education but not school education, health education. M is maternal child health and family planning. E is EPI, which has now become UIP, nutrition and treatment of common ailments. So that was about the principle of primary healthcare. Okay, now we are also stressing on the concept of what? Universal health coverage. Okay, primary healthcare has now kind of shifted to the concept of universal health coverage, which includes essential healthcare services. Okay, essential healthcare services should be provided to everybody, plus it should also ensure what? Financial protection. Okay, plus financial protection. That means for the first time we are now talking about providing insurance cover. Okay, insurance cover for IPD, inpatient care. Okay, that is in universal health coverage. And in this, the range of essential services other than the elements has also been extended to cover what? This has also been extended to cover everybody, NCDs. That is very, very important. Other than RMNCH plus A, now we are covering NCDs also. So we have broadened the range of services plus Ayush facilities. And which is the initiative which is helping us achieve universal health coverage in India? So this is the concept of Ayushman Bharat is an initiative. Okay, this you can refer in the main lectures also, detail of universal health coverage. As of now, just remember Ayushman Bharat is an initiative to cover UHC in India. Good quality services also plus financial protection. Like in Ayushman Bharat, it is providing us 5 lakh per insurance coverage of 5 lakh per family per year. Number of family members is no restriction. Okay, so that is a financial protection which is being offered under the program. Now, what are the 4 principles or pillars on which it is based? This is a very important MCQ. So it is based on certain principles or pillars, this concept of primary healthcare. Okay, number 1, it is based on the principle of community participation. Number 2, it is based on the principle of appropriate technology. Number 3, equitable distribution. And what is the 4th one? Intersectoral coordination. Okay, so it is based on the principle of community participation. That means, see, if I want to bring a change in a community, I need a person from that community to help me out in it. If I go to a community and tell them, get your children vaccinated, they don't know me, so they'll tell, okay doctor, and that's the end of it. But if somebody from the community only tells them to do this, they will listen because they know that person belongs to their community. So community participation ka example is asked in exam. The example is grassroots level workers. What are the grassroots level workers? We'll be discussing ahead also. They are nothing but field workers. Okay, those who are working in the field, not in any healthcare setup. They are in the field. Okay, so most important they give is an ASHA. ASHA is an example of community participation. Then what about appropriate technology? I'll just write appropriate technology here. Appropriate technology simply means that, okay, good quality, cost-effective services should be provided. Okay, good quality, cost-effective services to be provided. And what is the example of appropriate technology? A lot of examples are there. Like example, use of ORS. For diarrhea, we are not using any hi-fi medicines, simply using ORS, which can control dehydration also, and it is the best modality. Okay, ORS, use of ORS. All right, then very important example of appropriate technology which comes in our exam is VVM. Okay, vaccine while monitor. Now vaccine while monitor checks whether the potency of the vaccine has been damaged by heat or not. Now this vaccine vial monitor is simply a heat sensitive label. Okay, this is simply a heat sensitive label which is placed on the body, on the neck of the ampule or on the cap. Okay, it's not some hi-fi laboratory technique. Okay, so this is an example of appropriate technology. KMC, kangaroo mother care, this is equivalent to appropriate technology. Then Shakir's tape. Now Shakir's tape is used for assessment of malnutrition status at the field levels. Okay, so we are not using something very hi-fi, we are just using a color-coded tape to assess that. Okay, so examples of appropriate technology and community participation, these are all PYQ which have come in our exams. Okay, chalo next, equitable distribution, that health services should be free for all. Okay, if they are free for one, it should be free for all. Intersectoral coordination, health sector cannot work alone. It needs support from all the other sectors as well, like environment, education, everything. Okay? So that is all about primary healthcare. You have to revise the definition. You need to revise the 4 A's, elements as well as principles. Very, very important. Okay. Now let us talk about levels of healthcare. So when you talk about levels of healthcare, guys, always remember there are 3 levels of healthcare. Okay. And this level of healthcare is separate for rural setups and urban areas. Okay. So I will just put this thing over here. It's different for rural as well as urban areas. Now you remember what is the definition of a rural area, guys? Rural area ka definition tha, the population is up to 5,000. Okay, rural area mein population is up to how much? 5,000. And for rural area, 75% of male working population. Okay, 75% of male working population is involved in which sector? Is involved in agricultural sector. Okay, and when you talk about urban areas, guys, when you talk about urban areas, remember population is more than 5,000 and 75% of male working population. Okay, male working population is involved in which sector? Non-agricultural sector. Okay, so now based on this, for it's the levels of healthcare, it's separate for rural and urban areas. But of course, we have a primary level, we have a secondary level and a tertiary level. At the primary level, in rural areas, what do we have now? We have sub-centers and primary health centers. Now these sub-centers and PHCs under the Ayushman Bharat is being upgraded to what is known as health and wellness centers, which will provide wider range of services. Okay, so at primary level in rural areas, sub-center PHCs, they are now being upgraded to health and wellness centers. In urban areas, what do we have? In urban areas, we don't call it as sub-centers, but we say that what is present, Swasthya Chowki and urban primary health center or urban simple urban health center, either urban primary health center or urban health center. At secondary level, at rural areas, what do we have? CHCs, community health centers, SDH, sub-district hospitals or district hospitals. And on the urban side, okay, what do we have at secondary levels? Very important, urban CHC. This is further divided for a metro city and for a non-metro city. Okay, now at tertiary level, at both the places, everybody, we have medical colleges. Okay, remember this, medical colleges and super speciality hospital. Okay, medical colleges and super speciality hospital. Tertiary level, here also we have medical colleges and SSH. Now what is most important over here, that which is the first referral level? If anybody asks you guys which is the first referral level, which actually comes as MCQ also, first referral level, is it sub-center PHC? No, first referral level is CHC. Okay, because at PHC only we have a medical officer, and when he sees and refers, that becomes the first referral level. So CHC is the first referral level. Okay, never say PHC. So this is the classification of levels of healthcare. It's separate for rural and urban areas. Okay, what is the difference between a rural and urban area? I've told you. Now what is happening at primary level in rural area? We have sub-center and primary health centers. Urban area we have urban PHC or urban health centers and स्वास्थ्य चौकी, सेकेंडरी लेवल CHC, सब डिस्ट्रिक्ट हॉस्पिटल, डिस्ट्रिक्ट हॉस्पिटल्स, यहाँ पे भी CHC है, सेपरेट फॉर मेट्रो एंड नॉन मेट्रो सिटीज. ओके, नाउ लेट अस स्टार्ट विद द फर्स्ट वन, रूरल एरियाज. So we'll just do a comparison of sub-center, PHC and CHC. Okay, what is the level of healthcare? The first question, what is the level of healthcare provided by sub-center? So we all know this is primary level. PHC also primary level. CHC is providing us secondary level of healthcare. Okay, that's the first question. Then the population that each center caters. Like one sub-center, everybody caters 1 per 5,000 population in which area? Plain area, and 1 per 3,000 population in which area? Hilly areas. What about PHC? 1 per 30,000 population in which area? Plain area, and 1 per 20,000 population in which area? Hilly area. What about CHC? 1 per 1,20,000 population in plain area, guys, and 1 per 80,000 population in which area? Hilly area. Okay, now remember these sub-centers and PHCs 24/7 PHCs, all that also are there, but generally sub-centers and PHCs are now being upgraded to health and wellness centers under our Ayushman Bharat. So that's the population norm. Then categorization. So what do we have to study about categorization? Always remember, categorization is being done based on delivery option or based on delivery facility. Okay, so is a sub-center categorized further? Yes. So remember, there is a type A sub-center and there is a type B sub-center. Type A sub-center is where there is no delivery provided, no delivery option provided. Type B sub-center mein delivery is facility is happening. Okay. PHC, again, this is important. Type A. So what is type A PHC? Less than 20 deliveries per month. And what is type B PHC, everybody? Type B PHC is more than equal to 20 deliveries per month. In CHC, no such categorization is there. Okay, this is very, very important. Let's study further. Okay, total number of staff. Now, if I ask you staff, abhi just write 3 to 4 in a sub-center. In a PHC, we have for a type A PHC, okay, type A PHC 13 to 18, and for a type B PHC 14 to 21. For a CHC 46 to 52. Here also type A sub-center 3 and type B sub-center, everybody, 4. I'll tell you the staff in a separate slide. Okay, then this is important. What about the number of beds? Now, as for the beds, everybody, see, technically in a type A sub-center, earlier we did not give a fixed number. But as per the latest update, okay, type A may there could be 1 to 2 beds, and type B, where delivery is happening, 2 to 3 beds. Okay. In PHCs, again, type A, we can have 4 to 6 beds. Type B, we can have 6 to 10 beds. Okay. But if like only one single option you have to select, you can go for a 4 to 6 beds. In a CHC, we can have up to 30 beds. All right. So that is about the beds. Now, whose responsibility it is to manage a sub-center? Responsibility lies with the central government. What about PHC? The responsibility lies with the state government. And CHC, again, the responsibility lies with the state government. Okay. So that is about the distribution, which you must know, comparison between sub-center, PHC, CHC. Villages. Sub-center can supervise 4 villages. Okay. 4 villages. PHC 29 villages. And CHC के अंदर आता है 158 villages. Okay, so this is like a very basic gist which I have provided you. Population, categorization and beds, most expected in exams. Now, if somebody asks you about the staff pattern, okay, please remember staff pattern mein in a sub-center we said 3 to 4. Who are these 3 to 4 people? So, in a type A sub-center we have 3 and in a type B sub-center everybody we have 4. Okay, but who are these 3 and who are these 4? So remember, sub-center has no medical officer. Okay, this is one MPW male, okay, or HW male. What is MPW male and HW male? Multi-purpose worker male. Okay, this is what? Multi-purpose worker male. And HW क्या होता है? This is what? Health worker male. Okay, so that is very important. So this is 1 and 1 health multi-purpose worker female, okay, or health worker female, or this is also known as auxiliary nurse midwife, ठीक है, and one safai karamchari, okay, one safai karamchari, no doctor. But this is for a type A subcenter. If we have a type B subcenter, guys, where delivery is happening, so what are we going to have? One multi-purpose worker male, but two multi-purpose worker female / ANM, okay, so two, and also Safai Karamchari. So you need to know the people who are posted at a sub-center. When you talk about the staff pattern at PHC, type A 13 to 18 and type B 14 to 21, we don't need to too much of detail, but you must remember in PHC, essential is medical officer, okay. Now we have a medical officer, and who is desirable, everybody? Ayush becomes desirable. Now, more important are the paramedical health workers. There you had ANM, all right, or a multi-purpose worker, male and female. Here, who's posted at a PHC? Here we have a health assistant, okay, the main people you need to know, male and a health assistant, female, all right. Other than that, we also have a lab technician, all right, we have a lab technician, and we also have a pharmacist. Please remember, lab technician and pharmacist technically in India should be present 1 per 10,000 population, but at a PHC we definitely have them. So they are the most important people who can come in your exams. Health assistant, they definitely ask you, so 1 per 30,000 in plain area, 1 per 20,000 in hilly areas. Now in CHC, guys, this is where we have all the specialists. Now specialists matlab kaun hai? So here we have an MD medicine, okay, then we have MS surgery, okay, so medicine, surgery, obs and gynae, okay, obs and gynae, MD pediatrics, okay, all of these people are posted over here. Then what will they do without an anesthetist? Okay, anesthetist, okay, dental surgeon, yes, a dental surgeon is present, okay, dental surgeon is present, ear, nose, throat, ENT is also present, ophthalmologist, very important. Ophthalmologist, they ask a lot of questions, please remember, one ophthalmologist, okay, this is a PYQ, one ophthalmologist can be present technically up to how many CHC? 5 CHCs, okay, 1,20,000, almost for 5 lakh population, but WHO says that one ophthalmologist should be present for 50,000 population. Then we also have an MD PSM over here, okay. Then we also need a statistician who should be posted over here, okay, statistician. Other than, of course, medical officer, Ayush, ye sab to rahenge, okay. But what about paramedical worker? Like in a sub-center, you had multi-purpose worker, male, female. In a PHC, health assistant, male, female. What about CHC? We have health supervisor, male and female. Other than that, of course, we have pharmacist, okay, of course, we have lab technician, but someone who came in the exam, which was very, very important, is paramedical ophthalmic assistant, radiographer, not a radiologist, radiographer, okay. And in exam, they also ask you, where is a registration clerk posted? So he is posted at a CHC. Okay, so the bare minimum of number of people you must remember. Ye question zarur aata hai. One ophthalmologist up to 5 CHC. Okay, so that was the staffing pattern. So this was about a general distribution. Now comes who's the grassroots level workers. Okay, please remember, grassroots level workers means field level workers. They are not posted at a sub-center PHC, CHC, no. They are working at the fields. So who are they? What you have to remember, you will compare one Asha and Anganwadi worker and study them together. All right, in the next slide, you're going to compare village health guide and train birth attendant and study them together. They are the main people who are the grassroots level workers. Okay, so Asha, I'll tell you some other points also about Asha. See, both begin with an A. So both have to be 10th pass. Please don't say 8th pass. Both are 10th pass. Asha is present 1 per 1,000 population still, okay. This is the existing norm. What is this? Existing norm. But what is the proposed norm for Asha? 2 per 1,000 population. Okay, this is what proposed norm. Existing norm to 1 per 1000 hona chahiye. Proposed is 2 per 1000. Okay, then Anganwadi worker is 1 per 400 to 800 population in the plain areas. Very important. And 1 per 300 to 800 population where everybody in the hilly areas. Okay, that is what is Anganwadi worker. Duration of training for Asha worker is 23 days. Training for any period, like continuous 23 days in a period of 1 year. Now, Anganwadi worker is dealing with children, so she has 4 months training. The minimum I'm telling you about grassroots level, Asha and Anganwadi, which you must know for your rapid revision. Other people that have written is, this is village health guide. Okay, and what is this? This is TBA. TBA means what? Trained birth attendant. So village health guide, again the population norm is 1 per 1000, 1 per 1000. Educational criteria. See, trained birth attendant ke liye educational criteria, everybody, is very, very important. It's like nil. Government of India said to become a trained birth attendant, you don't need any educational criteria. Okay, now village health guide. This is a guide. So at least some class education hona chahiye. Okay, so this is how much? 6th pass. All right. Duration of training. Now here, if you talk about village health guide, duration of training, everybody, half of 6, 3 months. Okay. And here, trained birth attendant, 1 month. So if a trained birth attendant gets a duration of training of 1 month, and she is able to conduct 2 supervised deliveries during her training period, she becomes a TBA. Okay? She should be able to conduct how many supervised deliveries? 2 supervised deliveries. Conduct 2 supervised deliveries during training period. Okay, she should be able to conduct what? 2 supervised delivery during training period. So that is TPA. Anything can come. The difference between village health guide as well as trained birth attendant is equally important. Please don't forget about it. So they are all posted at grassroots level at field. You will be studying separately who is posted at grassroots level in the urban areas. Also remember guys, ANM. ANMs, although they are at sub-center, they often visit the fields at regular intervals. Okay. All right. This is a very famous question. Function of health worker female now. All right. So she prepares malarial slides. No. Chlorinates water? No. Collects urine sample? No. Function is perform 50% deliveries. Okay. All this is the worker. The rest functions are of the male multipurpose worker. So I just wanted you to revise that. See, health worker female, she can register pregnant female. Please remember one thing. TBA can also register pregnant female. Trained birth attendant can also register whom? The pregnant females. Okay. So urine and hemoglobin test, not collecting the sample. Testing is what she will do. Of course, conducting deliveries. Then PNC visits can be made by her. ANC visits also. Family planning mein, this is a PYQ. She is responsible for maintaining eligible couple register at the sub-center. Okay. Distribute conventional and oral contraceptives. Contraceptives can be distributed by male also, female also. MTP identification and referral, yes. Nutritional, providing vitamin IFA, both can do, male and female multipurpose worker. Immunization also both can do. All right. Notify the medical officer if we identify any communicable, non-communicable disease. That also both can do. Vital event record maintenance, record keeping. That is important. But most important is register pregnant female, conduct delivery, maintain eligible couple register. And at any one point of time, health worker female should be able to conduct 50% of deliveries. Not conduct, I mean 50% of women, pregnant female should be registered. Male multipurpose worker, remember 3 things before I teach you. Okay, chlorination. Prepare malarial slides every fortnightly. All right. Chlorination, prepare malarial slides, and also collect sputum sample. These are the 3 most important function of health worker male. Maintaining of records, both can do. This is special malaria slides. Identifying cases of communicable, non-communicable disease, both can do. Giving ORS, giving contraceptives, both can do. Vaccinating, both can do. chlorinate water bodies is the function of male multipurpose worker, and also collects sputum samples. Okay, here you can write collects sputum samples. So you must know the job responsibility of male and female multipurpose worker. Then ASHA worker, some points I want to tell you. She's a grassroots level worker. Okay, she's a grassroots level worker. The first point, she is an example of, discussed before, community participation. Okay, she is an example of community participation, the principle of primary health care. Okay, second, she can be married. Okay, she can be divorced. All right, she can be separated, but she has to be a local resident of that community. Okay, what is she? She is a local resident of the community. What is her age? Very, very important. Never say 19, 18, no. 25 to 45 years. She's never a single woman. And preferably, preferred, okay, preferred, not very hard and fast rule, preferred that she has at least one child so that the women can open up to her more. But if she doesn't, that's okay. That's one of the preferable criteria. All right. Then who selects the ASHA worker? She is selected by village panchayat. Okay, under whom? She is selected by village panchayat under supervision of medical officer. Okay, so she is accountable to village panchayat. Okay, don't say medical officer, accountable to village panchayat. All right, who trains her, or what is her duration of training? Her duration of training, everybody, is 23 days over a period of 1 year. Then who trains her? Anganwadi worker / ANM provides training. Okay, provides training. Very, very important. All right. Then what is the existing population norm? Please remember, existing population norm, everybody, is 1 per 1,000. And what is the proposed population norm? So the proposed population, guys, is 2 per 1,000. Okay. These are some points for ASHA worker which can come in your exam. Okay. All right. One more point, that what is her main function? She is a mobilizer. Please remember, she cannot do deliveries. Okay. She cannot give vaccines, but she collects people for delivery, women for deliveries, and she also collects every child to get them vaccinated and pregnant female. So you can see roles and responsibilities. She is a mobilizer basically. Remember, she does not conduct delivery. Okay. Does not conduct delivery. Although she carries a disposable delivery kit, but she is not trained to conduct deliveries. Okay, she does not give vaccines also. Okay, but she is accompanying pregnant women and children. Okay, then I wanted you to know this. She facilitates construction of community or household toilets. Okay, she is acting as a depot holder, and village action plan, comprehensive health plan or village health plan, who is developing, the main responsibility of developing village health plans lies with the ASHA worker. Okay. One more point, principal unit of administration in India, please remember, is a district. Now let us look at urban healthcare delivery system, just like rural healthcare delivery system. Okay, so we have at primary level, okay, instead of a sub-center, we have Swast Chowki. But before that, urban PHC. This is present for 1 per 5,000, 50,000 population. Okay. Now, if PHC is within some distance from a slum, then a PHC can also be present up to 25,000 to 30,000 population. But in rapid revision, you can at least remember urban PHC 1 for every 50,000 population. Then we also have a Swasthya Chowki. Okay, one Swasthya Chowki, everybody, is 1 per 10,000 population. And who's posted here? Urban ANM. Okay, just like sub-center mein ANM thi na, yahan pe it's urban ANM. Urban ANM is also for 1 per 10,000 population. And also we have over here a community health worker. In a Swast Chowki, we also have community health worker. Okay. Next important thing is secondary level. So in secondary level, the population norm for CHC is very important. So for a metro city, one CHC is present 1 per 5 lakh population, and CHC में non-metro city में it is present for just half of this, that is 1 per 2.5 lakh population. Tertiary level, you don't have to worry, it is medical colleges and super specialty hospital. But they can definitely ask you the beds, so remember, metro city up to 100 beds, non-metro cities 30 to 50 beds. Okay? That is important for urban healthcare delivery system. But who's the grassroots level worker who's working in the who according to urban healthcare delivery system? I mean grassroots level worker or field level worker in urban areas, just like ASHA. Okay, the grassroots level worker in urban areas, everybody, is USHA. Okay, and one USHA is present for 1,000 to 2,500 population, you could say. Okay, one USHA, 20,000 to 2,500 population, or 252, you could also say 500 households. Roles, responsibilities, everything are the same, just like an ASHA. Okay, that is important. All right. Now, this is a small, summed up or a update also here. I can tell you, see, health and wellness centers are now being created according to Ayushman Bharat, and we are upgrading the existing health sub-centers and PHCs to health and wellness centers, where we are providing wider range of services. Like other than RMN, CH plus A facilities, we are also now providing services for NCDs as well as Ayush. Okay, so rural hilly areas 3,000, rural plain areas 5,000. Nothing has changed over here. Now I told you if there's a health and wellness center in an urban area, it could also be present for 15,000 to 20,000 population. Okay, urban mein agar health and wellness center hai, this is like an update. Okay. Otherwise, we say urban health center that is present for Swasth Chowki is present for 10,000 population. But if it's converted to a health and wellness center, 15 to 20,000 population. Okay, PHC 20,000, rural areas, hilly area, plain areas में 30,000, urban PHC 50,000. Polyclinic, this is an update. Urban polyclinic is 2.5 से 3 lakh population. CHC we already know, in rural areas, plain areas, 1 CHC per 1,20,000, hilly areas 1 per 80,000. Non-metro and metro we have already done, 2.5 and 5 lakh population. I just want you to know, if somebody asks you, do we have health and wellness centers in urban areas? Yes, it is for 15,000 to 20,000 population. This is just a summary of beds which I have provided for you. This is again an update. Okay, so you could revise this. All right, let's revise some questions. What is the statement? Which of the statement regarding primary health center is correct? Provision of total beds at PHC is 4 to 6. Yes, if you remember, type A 4 to 6, type B में 6 to 10, but overall if they ask you 4 to 6. One PHC covers a population of 3,000 in hilly areas. No, one PHC covers the population of 20,000 in hilly areas. Staff at PHC must have an OBG. No, not at PHC, at a CHC. PHC with more than equal to 10 deliveries per month is type B. No, more than equal to 20 deliveries per month. Okay, so what is the correct statement here? This one. Yes, one PHC supervises how many sub-centers? Now, you know, one PHC is 30,000 in plain areas. Okay, and one sub-center is 5,000 in plain areas. So 5 into 6 is 30,000. So one PHC supervises 6 sub-centers. Guys, here I would like to ask you something. One urban CHC is supervising how many urban PHCs? Remember, 5 to 6 urban PHCs. Okay, ये भी has come as an option in one of the MCQs. One urban CHC is supervising 5 to 6 urban PHC. But if I say one CHC is supervising how many PHC? So that will be 4 PHC. Okay, a trained birth attendant is for a population of 1,000, just like a village health guide. All are grassroots level workers except Anganwadi, yes. Multi-purpose worker, health assistant, TBA. TBA, yes. Now, multi-purpose worker or health assistant. See, multi-purpose worker can be ANM or multi-purpose worker, male and female. They are posted at sub-center. But like I said, they make regular visits. Okay, they make regular field visits. Okay, although they are posted at sub-center, they are visiting the field. But health assistant, okay, health assistant male or health assistant female, where are they posted? They are PHCs only. They don't have to make any visit as such. Okay, health assistant female is also known as a LHV. Don't get confused. This is what? Lady health visitor. Alright, so that is again very, very important. Okay, but suppose there was a question where they said Anganwadi worker, TBA, आशा एंड मल्टीपर्पज वर्कर, फिर तुम्हारा आंसर क्या हो जाता? मल्टीपर्पज वर्कर, बिकॉज दीज थ्री आर प्राइमरीली पोस्टेड इन द फील्ड लेवल्स. ओके, alright, first referral unit done, CHC. Primary urban health center covers a population of 50,000. But if I say health and wellness center in an urban area, 15,000 to 20,000. That's it. This is an important chapter, guys, where I've tried to provide you a basic summary of all the healthcare delivery system, which is very, very important. Okay. Thank you so much. So hello dear students. Welcome back to this rapid revision video on health planning, planning committees and health management techniques. So I'll be giving out this topic in a very concise, crisp manner. Okay. First, the definition of health planning. Now, it is an orderly process of defining the community health problems, identifying the unmet needs, surveying the resources to meet them, establish priority goals that are realistic, and project administrative actions to accomplish the purpose of proposed program. So basically, when we have to do a health planning for a community, I just can't go to any community and tell them start immunizing your children, start taking contraceptives, do this, do that. No, I first need to identify what are the health problems. Okay, that is identifying the health problems over here means making a community diagnosis. Then I have to identify what are the unmet needs. Okay, and then survey all our resources. What were the resources? As we have done in the main lecture also, manpower, money and material. Okay, do we have manpower, money, material as well as technical skills? Okay, so we have to do that and then establish priority goals that are realistic, project administrative actions to accomplish the purpose of the proposed program. Okay, so that is what is health planning. More important than the definition, of course, is the planning cycle. Again, a quick heads up for all of you. You have to know planning cycle, you have to know communication cycle, demographic transition model ka cycle. Okay, then you have to know family cycle. Okay, these are some very important cycles which can, and disaster cycle, which can come in your exams. Okay, so let's start with the steps of planning cycle. So what have I taught you? The first letter is A and the last letter is E. Okay, so A over here means we have to do an analysis and E is always done at the end, which is an evaluation. Okay, so first you find out the problems of a health community, of a community. So that is analyze the health situation. In this we were taking the entire socio-demographic, we were doing the entire socio-demographic profiling of the community. Okay, we were trying to identify all its community problems, everything. Okay, then we were setting the goals and objectives. Okay, assessing the resources. Goals and objectives goals means what do I want to achieve? Like as a public health officer, I might want to decrease infant mortality rate in my community. Okay, so that's my goal. The objective would be how can I decrease infant mortality rate by increasing immunization coverage? So that becomes my objective. Assessment of resources always means we have to look at manpower, money and material. Okay, how much of all these things we have. Plus we also have to look at the technical skills. Okay, so we are assessing the resources in the form of manpower, money, material and technical skills. Accordingly, we have to set up priorities. So if there is deficient immunization coverage or if there is family planning is poor, where would I divert my resources first? Okay, that is priorities. Then we'll formulate a plan that, okay, if I choose to increase immunization coverage, I have to make a plan. I'll be conducting so many health education sessions. I'll be ordering so many vaccines, maintaining a stock of all them. So that's a plan. So that I'm putting on paper, but then I have to implement that also. So program and implement. Then we do monitoring. Always remember, monitoring is analysis of, or it's a day-to-day activity. Okay, monitoring is what? Monitoring is something which is ongoing, day-to-day activity. Okay, day-to-day activity. Monitoring is actually checking whether I'm in the right process. Okay, whether the process is correct. Okay, of what I'm doing. All right, and evaluation. Remember, monitoring is also done like it's an internal thing. Okay, it's like an internal audit. Okay, I don't want someone from outside to come and monitor. No, last May what happens? Evaluation. Okay, so who does the evaluation? Everybody. Evaluation is always done by external agency. Okay, or evaluation is something in which we are trying to look at the outcome. Like I said, I have to increase immunization coverage, I have to decrease infant mortality rate. So did we achieve that or not? So evaluation is outcome oriented. oriented. Okay, it's being done by an external agency and it is done periodically. Okay, it's done periodically. Monitoring is done daily, day-to-day activity. Like you, when you're preparing, you can monitor yourself. If you were supposed to do 10 MCQs every day, did you do it or not? But your evaluation is being done by National Board of Examination, which is being done at the end. Okay, after 1 year. Okay, when you appear for the exams. So always remember, for planning cycle, the first letter is A and the last letter is E. So analysis, set your goals and objectives, establish priority, assess resources. Based on that, establish your priorities, formulate a plan, then program and implement, monitor and evaluation. Another very important thing, which is very, very important, what is the definition of goal? Okay, so goal is the ultimate desired state. Okay, goal is ultimate desired state towards which all objectives and activities are directed. Okay, it's the ultimate desired state towards which all our objectives and activities are directed. Remember, goal is what? Goal is, goal is not constrained by time. Okay, it is also not constrained by resources, not resources constrained. Okay, so goal is something that I want to ultimately achieve. Okay, so it should not bound, it should not have the limitation of time attached to it. Plus resources, I can take whatever resources I want to achieve my goal. Okay, so this also follows what? This also follows all or none phenomenon, meaning goal will either be achieved or not achieved. Okay, all right. Then the next one is objective. What is objective? So objective is planned endpoint of all activities. Okay, you'll be asked the definition. Like objective has always to be SMART. Okay, that means SA, it means it has to be specific. Okay, M, it has to be measurable. Then it should be achievable. Then it has to be realistic. And it also has to be time bound. Like my goal as a public health officer was to decrease. Okay, I'll just put an example. Goal was to decrease what? Goal was to decrease the IMR in a community, infant mortality rate in a community. That was my goal. For that, I set my objective. So what is the objective? Objective is to increase immunization coverage. Let's say by whatever was lacking, 70-80%, whatever. Immunization coverage by 70% among, let's say, 0 to 5 years. Okay, so that was my objective. And then to achieve this, so it's measurable, it's achievable in I could say 1 year. Okay, then what is target, everybody? Target is nothing but degree of achievement of objectives with time. Okay, it is the degree of achievement of objectives with time. That is what is target. All right. So like for this, to increase immunization coverage, I had to conduct 2 health education sessions. So 2 health education session conducted. Okay, that is like what is a target. Okay, so you need to know the definition. It is very, very important. Not constrained by time or resources is goal. Okay, planned endpoint of all activities is objectives, and target is degree of achievement of objectives with time. All right, these 3 definitions can come. So from the first part, the planning cycle and the definitions are important. Now we must know something about the planning committees also. Okay, so the most important planning committee was Bohr committee. Okay, which was given by Sir Joseph Bohr. And what was the name of this committee? Health Survey and Development Committee. Okay, now Sir Joseph Bohr, this was before independence in 1946. And Sir Joseph Bohr was a very ambitious man. Okay, before even India got its independence, he he started talking about health survey and development. So he gave ambitious plan. Like he set a short-term plan. Okay, short-term plan was where he said that there should be one PHC for every 40,000 population. Imagine one PHC for every 40,000. In current time also we have one PHC for 30,000 population. And there was a long-term plan which was called as 3 million plan. What was this plan supposed to do? This plan was supposed to benefit 3 million people. Okay, this was supposed to benefit 3 million people, in which we have seen that at primary levels or we should have setups with 75 beds. Okay, at secondary level setups with 650 beds, and at tertiary level setups with 2,500 beds. Okay, so that was the long-term plan. Then he gave some boring concepts. I hope you remember what were the, from bore you have to remember what? From bore you have to remember the word board. So he gave some boring concepts. What was that? 3 months training, 3 months internship in PSM post MBBS, although it's a good thing, but still. And you know, social sciences, history, geography was boring in school. So he gave the concept of social physicians, and school health guidelines were laid down by Rain. So he gave some boring concepts. The boring concept was number 1, 3 months training in PSM, social physicians, and he started the concept of school health. Please remember, concept of school health was given by Bohr. Okay, concept of school health services was given by Sir Joseph Bohr. But it was improvised by, okay, it was improvised by Renuka Roy. We have studied this also. It was improvised by Renuka Roy. Okay? But the concept, like when children start going to school earlier, it's a boring thing only. Then gradually they start enjoying. So that's how you can remember. Plus, Sir Joseph Bohr also talked about providing comprehensive healthcare, which is a healthcare right from the moment the baby is conceived till the person dies. So from womb to tomb. Alright. So that was given by Sir Joseph Bohr. After all the plans, okay, all the short-term plan, 1 PHC for 40,000 people, 3 million plans, okay, 3 months training in PSM, social physicians, school health services, all these are important over here, okay, and also comprehensive healthcare. Then came the second one. We all know second committee was Mudaliar. Now we know that Mudaliar was an IS officer, okay, Mudaliar was what? Mudaliar was an IS officer. So he said that why are you talking about development first? Please first let us talk about planning. So what was the name of his committee? Health Survey and Planning Committee, not Development Committee. And he said, let us strengthen the existing health setups, okay, and he set up what is known as a cadre of All India Health Services. He is responsible, he was an IS, so he spoke about forming a cadre of All India Health Services, okay, a cadre of All India Health Services. So a cadre of All India Health Services was given by whom? Mudaliar Committee. Okay, the other name of the committee is also important, and this is what he did. Then came a next person was Chadda, okay. All right, Chadda Committee. Now, Chadda Committee gave 2 things. How do we remember it? Chadda slept in small clothes. He got bit by mosquito. So, he said, let us focus on malaria control activities. Okay, malaria control activities. And also, he said there should be family planning activities. Okay, family planning services. All right, so he proposed 2 things, malaria control and family planning. Since he was proposing 2 things, he said, please give me at least provide me 1 basic health worker. So to achieve both the things, he said, please provide me 1 basic health worker. Okay, 1 basic health worker for every how much population? 10,000 population. Okay, so Chadda Committee talked about malaria control activities and also family planning services. And he said that please give me 1 basic health worker for every 10,000 population to achieve this. After this, you all remember comes Mukherjee. Now, how do we remember Mukherjee Committee? Okay, so please remember now Mukherjee Committee. Mukherjee is a Bengali. Okay, Mukherjee was a Bengali. And there are so many Mukherjees in Calcutta. Okay, so what did Mukherjee Committee? That's a way to remember. Okay, what did Mukherjee Committee say? That please de-link, okay, separate. De-link what? De-link family planning services from malaria control. De-link family planning services / activities, okay, / activities from what? From malaria control, okay, both of them should be separate. De-link family planning services from malaria control, okay, that was Mukherjee. Then of course there's a Jungalwala Committee. Now Jungalwala, I have taught you how that, remember from the word Jallianwala Bagh. Okay, remember Jallianwala Bagh. What happened in Jallianwala Bagh? All Indians, okay, unified. Okay, Indians unified to fight against the Britishers. Okay, so that is what happened in Jungalwala. Jungalwala said he gave a committee on integration of health services. This is very important. Okay, so what was actually Jungalwala saying? That preventive, promotive, curative, rehabilitative services should not be offered separately. Okay, all the services, preventive, promotive, ठीक है, preventive, promotive, curative, all right, preventive, promotive, curative, rehabilitative services, okay, should be offered together. All right, preventive, promotive, curative, rehabilitative services should be offered together, not separately. Then he gave some jungly provisions: equal pay for equal work and ban on private practice. So this you can remember by the word jungly provisions. Okay, this is just for you to remember. Okay, equal pay for equal work and ban on private practice. Okay, but a question that commonly turns up is, what is the Committee on Integration of Health Services? Jungalwala Committee. Then of course we had Kartar Singh. Okay, now Kartar Singh was a Punjabi. You all know Punjabis work in team. Okay, so that's a way to remember. So he introduced the concept of multi-purpose health workers at sub-center level, both male as well as female. After this comes Srivastava. Now please remember, in Srivastava it is SHR. So how did we learn it? You just have to reverse it to RHS. So when you reverse it to RHS, it includes all the things that start with an R basically. Okay, so here we were focusing more on rural health services. Okay, we wanted to promote rural health services, referral services. Okay, all starting with the R. Rural health services, referral services. And ROAM scheme. What was ROAM scheme? Reorientation of medical education in India. Now because we targeted on promoting rural health services, guys, for that we said that let's create village health guides at village level. He gave the concept of creating bands of semi-professional and para-professional health workers. So for that, create village health guides. They should also have health assistants at PHC level. Okay? Plus, Medical and Health Education Commission development also was focused by this. But remember, from Srivastava, just reverse kar do SHR ko, you can do it as RHS. So all three R's: referral, rural services, reorient medical education, and for rural services, band of semi-professional, para-professional workers. Your question comes, concept of village health guide was given by Srivastava. Okay, after Srivastava, there is one more committee which you should know. Okay, this is Krishnan Committee. Okay, this is what Krishnan Committee. Now, what did Krishnan Committee do? Now, for rural areas, we had the Srivastava Committee. What about strengthening the health services in urban areas? Are we going to forget about urban slums? No. So, to save urban areas, Lord Krishna himself came down and he gave the concept of what? Urban revamping scheme. Okay, urban revamping scheme. Okay, urban revamping scheme. This is Krishnan Committee. The latest committee which is there is high level expert group. This was introduced, which is talking about two things: promoting universal coverage. What is the way to achieve universal coverage in India? Already discussed, Ayushman Bharat. Okay, and also about BSc community health. The duration for that is 3 years. Okay, high level expert group spoke about creating a cadre of BSc community health. Okay, that is important. But now, do we have the planning committees as of now, everybody? No, there are no. See, and in these planning committees, we right now have high level expert group. Okay, but please remember, the planning commission has been replaced by what? The planning commission has been replaced by, this is important, the planning commission has been replaced by Niti Aayog now. And what is Niti Aayog? Niti Aayog is National Institute, institution, okay, for transforming India. National institution बोलना, institute नहीं बोलना है, National Institution for Transforming India. Okay, what is this, everybody? This is the think tank for India. Okay, this is the think tank for India, everybody. All right, the chairperson is the Prime Minister. Okay, so that was in very short about the planning committees. Anything can come now. Now, when we talk about management, see, we are planning, but can your plan work out unless and until you are able to manage your activities? No. Okay, we might plan our day, everything, but the most important thing is if I've planned something, how is my management? So in simple words, you know, what is management? It is effective use of resources. Like for you students also, you have so many resources available to study now, but how are you utilizing the resources? That is most important. In public health, for health management technique, it is divided into two. The first one is, this is based on behavioral sciences. Okay, the first one based on behavioral sciences. So behavioral sciences, we refer to it as qualitative techniques. Okay, and what is the other one? Okay, what is the other one? This is quantitative techniques. Okay, this is what? Quantitative techniques. So one is based on behavioral sciences, referred to as qualitative techniques, and the other one is quantitative. In this, what is the mnemonic I have given you, which you will remember? Pokemon. Okay, Pokemon. So what is P? P say personal management. Okay, O say organizational design. You at least have to know the names, guys, because they ask you all our quantitative methods, all our methods based on behavioral sciences, except, or which one is not based on behavioral sciences, something like that. Okay, then this is what? Communication. I say information system. And what is MON? Management by objectives. Okay, so based on behavioral sciences are Pokemon, personal management, organizational design, communication, information system, management by objectives. Okay, now when you talk about quantitative, I'll just put it here so that we get space for it. You need to know all the names. Okay, quantitative techniques at least, and I'll just revise the most important ones which turn up in your exams. Okay, the first one, cost effective analysis. Cost benefit analysis, systems analysis. Okay, cost accounting. Okay, then more important is zero-based budgeting, which comes actually this, in this you can also say PPBS, program planning budgeting system. Okay, then another one which is very, very important, okay, which can turn up in our exams is network analysis. In network analysis, we have to revise two things, which is expected, PERT, what is it, and CPM, critical path method. All right, then what else can come in your exams? Work sampling. Okay, the other important one is work sampling. Decision making. Okay, so all these are quantitative techniques which are very, very important per se from exam point of view. Cost benefit analysis kya hota hai? What is it? In this, the outcome of a program, everybody, okay, is assessed in which terms? So the outcome of a program is assessed in monetary terms. Like your input is also money and your output is also money. Example, like NACP saved, okay, NACP saved $10 million this year. Okay, save $10 million this year. Means what? That if so many people would have fallen ill, okay, additional government would have spent $10 million in saving them, okay, in protecting them, treating them. Okay, so cost benefit, input is in money and output is also in terms of money. But when you talk about cost effective analysis, everybody, here please remember, this is very, very important. The outcome of a program is assessed in which terms? So it is assessed in, or like here it was being assessed in monetary terms, here it is assessed in which terms? Non-monetary terms. Now when I say non-monetary terms, what does it mean? The number of lives the program was able to save. number of lives saved, okay, number of heart attacks avoided, number of heart attacks avoided, okay, or quality gained, quality adjusted life years. So quality gained, remember this is an MCQ, this is the most comprehensive indicator, okay, this is the most comprehensive indicator of cost effective analysis, okay. Then number of cases of a disease decreased, okay, so incidence of a disease, okay, incidence decreased, okay, what do you call it? Incidence, new cases decreased, so incidence of a disease decreased. All this is what? All this is cost effective analysis, okay. So a question comes, most widely used in health programs, services, and most easier to interpret, okay. Please remember this is what? Cost effective analysis, okay. Similarly, most easier to interpret is also what? Cost effective analysis. And there is one more which can come in your exams, guys, systems analysis. Please remember, in systems analysis, okay, we compare two alternatives, okay, comparison of two alternatives on what? It is comparison of two alternatives on the basis of what? On the basis of cost effectiveness, okay, on the basis of their cost effectiveness. Like we have a CBNAT available and we have a sputum, so which is better? We compare on the basis of cost effectiveness. Network analysis is again expected, okay. Network analysis hota hai graphic plan of all events to be completed in order to reach an end objective. Like if I have to increase the immunization coverage of an area, there are a lot of activities which we have to do, okay. So we have to arrange all the activities in an order, okay. So that is what is PERT, okay. PERT is program evaluation review technique, okay. In PERT, what we do? We just do an event sequencing. What do I mean by event sequencing? It simply means that whatever activities have to be done, the events that have to be done, they are arranged in an order. So this is a probabilistic model, okay. Then when we've arranged all the events in an order, we calculate how much time is going to be taken by each of the activity, okay. So that one is what is known as CPM, okay. That is what? Critical path method, okay. क्या बोलते हैं? Critical path method, meaning CPM is actually event time sequencing, okay. Event time sequencing, like each of the activities or event is going to take how much of the time. So this is what? Deterministic model. This relies on which model? Deterministic model, okay. Each path is going to take, each activity is going to take how much time. So I'm accordingly going to find out that which path is going to take the longest time. So the longest time which a path is going to take, that is critical path method, and I need to find out the longest time so that I can do that activity before and I can achieve my objectives on time, okay. So remember, CPM is of the longest duration, okay. CPM is of longest duration. Like over here, if you see, start, okay. Now there's one activity which is taking, let's say activity A, B, 1 day, 2 day, okay. Then this is some activity, okay, takes only 1 day. This is D, E, okay. Now if you see this path, okay, if you see this path, everybody, it's taking altogether 3 days. If you see this path, 1 day. But if you see this path, 2, 3, 4 days. So which is the path? This one, C, D, E, till the finish, okay. This is the path of the longest duration. So this path which is of longest duration is critical path method. I have to start these set of activities before some time so that I can achieve my desired objective on time, okay. So network analysis, cost benefit, cost effective is very, very important, okay. Here I would like to tell you one more thing that can maybe turn in your exam is which is very important, is work sampling. Please remember, in work sampling, okay, what do we do? It is systematic observation and recording of activities, okay. Remember these buzzwords: systematic observation and recording of activities, okay. Recording of activities of whom? So the buzzword in your questions will be of like nurses, of doctors, okay, of lab technicians, all right, to increase the outcome, Okay, like I own a hospital, my hospital is running in a loss. So one day I go for a random visit, okay, and I see where everybody is spending their time and accordingly ask them to improvise. So you have to look at the word systematic observation and recording of activities of nurses, doctor, lab technicians. That is what is work sampling. This can also turn up in your exam because it is important. And one more we will revise is zero-based budgeting. Okay, what is zero-based budgeting? Like, see, every year a budget is released, okay, every financial year. Now, zero-based budgeting is we cannot ask for a new budget unless and until we provide justification of where the money allotted in the previous budget was spent, okay. So, justification for money allotted in the previous budget spent, okay, in the previous budget has been spent. Unless and until we provide a justification for the money allotted in the previous budget, we cannot ask for a new budget, okay. So these were some of the techniques that you should remember which can turn up in your exams, guys. Here there is one more method that I want to write is, remember, input output. Okay, input output technique is also there. Okay, input output may input in the form of manpower, money, material, output in the form of life saved, everything is looked after. Okay, so that was about health planning management techniques. Let's quickly see. Planning cycle includes analysis, evaluation, resource, all of the above. Correct sequence is very important. I told you evaluation has always to be at the end. So here evaluation is at the end. So ideally goal pehle hona chahiye, then objective, but then this is a PYQ. Goal refers to ultimate desired state towards which all our objectives and resources are directed. Okay, all our objectives, activities. So like here, if you read the definition, we have written also what is goal, everybody. So goal is something towards which, yeah, goal is something towards which all objectives, activities, and also add over here resources. All my money, manpower, material is directed towards that. Okay, so that is what is known as goal. All right, planned endpoint of all activity, this is objective. Okay, and discrete activity is like doing a target. All right, management technique which is most promising tool, please remember, it's cost effective. Cost accounting simply means cost structure of a program. Okay, recurring cost, non-recurring cost, all of those things. Input output, input in the form of manpower, money, material, okay, and output is in the form of like cost effective analysis, number of lives saved, okay, OPD attendance rate, all that is output. All right, so that's it. Thank you so much. Hello dear students, welcome back to this rapid revision video of preventive ops, gynae, pediatrics, growth and development, and certain points about school health to be discussed. Okay, this is important, so we need to do this in a concise yet crisp manner. So the first thing in antenatal care which they ask is that how many visits are recommended, how many visits are minimum, and things like that. So recommended ANC visits, if somebody asks you, it is 13 to 14. Recommended means the ideal, but minimum ANC visits now is 8. Okay, this is according to WHO, and this minimum ANC visits, which according to WHO is 8 now, this is per se known as antenatal care contact. Okay, instead of using the word visit, we are using a word care contact because it resembles or it portrays a stronger connection between the healthcare worker and the pregnant female. Okay, so according to WHO, minimum ANC visits is 8, but according to Government of India, if anybody asks you, so according to Government of India, minimum ANC visits are how much? How many? It is 4. Okay, according to Government of India. But according to WHO, the minimum visits should now be 8. Okay, so look over here. Recommended is 13 to 14, which is first 7 month, once every month, 7 visits. 8th month, twice per month, 2 visits. And 9th month onward, once per week, 4 to 5 visits. Now, this minimum ANC visits according to Government of India, everybody is what? It is 4. All right, according to Government of India. But if somebody asks you according to WHO, remember, it is now antenatal care contact. Or if anybody asks you minimum visits according to WHO, as of now, it is 8, guys. Okay, so first trimester 1 visit, second trimester 2 visits, and the third trimester 5 visits. Okay, so pay attention to the question very clearly. If it mentions minimum visits according to WHO 8, minimum visits according to Government of India 4, if it shares antenatal care contacts, we are referring to the ANC visits only. So that antenatal care contacts again become 8. Okay, all right. Now postnatal care is the care which is offered after delivery. Antenatal is before delivery. All right, so it is the care of the mother and baby after delivery. All right, the important thing is, according to Government of India, how many should be the visits? So it is again postnatal visits, 3 to 4 everybody. Okay, 3 in case of hospital delivery. Okay, 3 in case of hospital delivery and 4 in case of home delivery. Okay, 3 in case of hospital and 4 in case of home delivery. So in case it's a home delivery, so 1, 3, 7 and 42nd day. All right, 1, 3, 7 and 42nd day. That's what we are offering the postnatal care. Okay, now remember one thing. This postnatal care or ANC care, we are not talking about ASHA workers here. They have to be made at least by an ANM or a medical officer. Okay, so here we are referring to the care. When I say minimum postnatal visits according to WHO, so the person should be looked after by an ANM at least or a medical officer. At least one visit should be made by a medical officer. Okay, the thing that we study, home-based care of newborn, that is a different thing. Okay, home-based care of newborn, that's a different thing, which is being made by an ASHA worker, which are additional visits. Okay, so remember, if I ask you over here, home-based care of newborn. Okay, home-based care of newborn. All right, this is being made by an ASHA worker. Okay, these are additional visits. In case of home delivery, we had studied, it was 7 visits. In case of hospital delivery, everybody, it was 6 visits. And in case it was an LSCS, it was how many visits? 5 visits. But if somebody asks you minimum ANC care, minimum PNC care, that has to be made by at least a ANM or a medical officer. One visit definitely by a medical officer. Okay? So now let us look at some of the supplementations in pregnancy. Okay? So according to WHO, for folic acid, how much should be started? How much should be given? 400 microgram daily in the first trimester. And technically, folic acid should be started 1 month, at least 1 month before getting pregnant. Okay, at least 1 month before conceiving. All right, it should be started at least 1 month before conceiving, and that is how much? 400 microgram daily in the first trimester. From the second trimester, obviously, what are we offering? We are offering prophylactic iron folic acid. Okay, we offer what? Prophylactic iron folic acid. So prophylactic iron folic acid tablet should be given daily from the second trimester onwards. Okay, and it should also continue. Okay, iron tablets should also continue after delivery up to 6 months. And this prophylactic iron folic acid tablet is being provided under which initiative, guys? We already know that. We have revised also in nutrition, Anemia Mukt Bharat, okay, or Intensified National Iron Plus Initiative. And how much are we offering? 60 milligram elemental iron, okay, plus 500 microgram folic acid. WHO says from the first trimester, take 400 microgram. Then in the second trimester in India, we are giving prophylactic iron folic acid doses. So that is how much we are offering: 60 milligram elemental iron and 500 microgram folic acid right from the second trimester up to 6 months after delivery. For anemic woman, if a woman is anemic, we need to give iron folic acid twice daily. Okay. Cutoff for anemia in pregnancy is, it is 11. That's okay. Less than 11 gram per DL. Okay. So those are some of the important things that you must know. So let's talk about the energy supplementation in the antenatal period. Okay. So what is it according to National Institute of Nutrition? Okay. So it says that in pregnancy, the woman should take how much? Plus 350 kilocalories per day. Okay. Then in the first 6 months of lactation, how much? In the first 6 months of lactation. Now first 6 months. So 6 is 600 kilocalories per day. Okay. And in this like second 6 months, that is in the next 6 months, if you have to say, in the next 6 months, it is how much? Plus 520 kilocalories per day. Okay. This is it. And what is this plus? Plus is added to the energy requirement by a sedentary woman worker. And what was the energy requirement by a sedentary woman worker? If you remember, sedentary, moderate and heavy worker female. Okay, sedentary, moderate and heavy worker female. So this was, if you remember, 1660. Okay, this kilocalories per day, and this was 2100 and 2700 kilocalories per day, right? Okay, everybody, this is the same as what is required by a sedentary. The requirements by moderate and heavy worker female is the same as that required by a sedentary and moderate worker male. So plus, when I say, it has to be added to this amount, sedentary requirement. Okay, 1660 May you have to add this plus 350. But ideally, guys, here I would like to tell you one more thing. Other than NIN, it is also said that in first trimester, technically no additional calorie required. Okay, in the first trimester, ideally no additional calorie required. Okay, but if somebody asks you in the second trimester how much calorie is required, plus 350 kilocalories per day. Okay, and in the third trimester, everybody, how much calorie is required? So in the third trimester, it is plus 450 kilocalories per day. Technically, in the first trimester, koi additional calorie we don't require, okay, in pregnancy. So be very careful with the options as well as with the question. Okay, so that was calorie requirement. It's actually very, very important in pregnancy. Okay, weight gain in pregnancy is how much? So after first trimester, woman should gain 2 kg every month. If a woman gains more than 3 kg in a month, we can suspect preeclampsia, twins, diabetes. So technically, the weight gain in pregnancy is around 10 kg. Okay, you could say 9 to 11 kg. So on an average 10 kg. But if a woman belongs to what? If a woman belongs to lower socioeconomic status, okay, lower socioeconomic status, then how much is the weight gain over here? Then roughly it is 6 to 7 kg. So be very careful with that also. Okay. All right. What is the vaccination protocol in pregnancy? So we all know that if woman is a primary or she is a multi, okay, with last childbirth, okay, if she's a primary or multi with last childbirth, everybody, okay, more than 3 years ago, in that case she has to get 2 doses of TB vaccine. Now we only give TB vaccine, okay, first dose as soon as possible in pregnancy, okay, as soon as possible in pregnancy, okay. And when do we give the second dose? The second dose is given 28 days later, okay. But if, please remember, she's a multi, all right, with last childbirth, okay, within 3 years or less than 3 years ago, okay, that means the youngest child is 2.5 something, then only a booster dose required, okay, a booster dose of TD vaccine given. And when do you give this booster dose, everybody? Around the 7th month of pregnancy, okay. So this is the protocol which we need to remember. All right. Before this, I just want you to write one more thing over here, nutritional recommendations. Please remember which elements requirement, okay, are increased in pregnancy. So nutrient requirement, all right, just add over here, which nutrient requirements are increased in pregnancy. Okay, so which nutrient requirements are increased in pregnancy? If you remember from nutrition, the main chart also, iron and folic acid. And the nutrient requirement, okay, which is increased during lactation, everybody, if you want to refer to the values, go to the nutrition class. Calcium, okay, vitamin A, all right, and iodine. Just wanted to put this down for all of you, okay. Everybody, chalo. Okay, so this is about the antenatal period. What are the lab investigations that can be done? They also come as PYQ. At sub-centers, we can do pregnancy detection test, okay, hemoglobin examination, urine test for presence of albumin and sugar, and rapid malaria test is also being done. But at PHC, CHCs, blood grouping and RH status. See, at sub-center, we are doing hemoglobin, but blood grouping, RH, PHC, CHC, or first referral units, VDRL for syphilis, HIV testing. Don't say HIV testing in sub-center. No. The rest of the tests at PHC. Rapid malaria test if unavailable at sub-center. Blood sugar testing we are not doing here at subcenter, at PHCs, and HbSAg. Okay, so other than hemoglobin, okay, all the basic tests which are offered in pregnancy, VDRL, HIV, HbSAg, they are being done from PHC level onwards. Then this is also a PYQ. What are the high risk pregnancies? So please just note this. Elderly primary, age 30 and above. Okay, she is a high risk pregnancy. More than 30 and years, no child yet. Okay, short stature, height less than 140 centimeter, 140 centimeter and less. These are all present as options in MCQs. Then of course, if it's a breech or a transverse lie, APH, antepartum hemorrhage, threatened abortion, preeclampsia, eclampsia, anemia, twins, hydramnios, previous stillbirths, okay, intrauterine death, manual removal of placenta, elderly grand multipara, then prolonged pregnancy. That means 14 days after expected date of delivery. Okay, the EDD is today, the baby has not yet come out. 14 days have passed. Okay, history of previous C-section or instrumental delivery. Then there's pregnancy with any other disease. Somebody has a cardiovascular disease, TB, liver disease, whatever. History of 3 or more spontaneous abortion. Okay, this is important. 3 or how many? 3 or more than 3 spontaneous abortion. Okay, plus history of infertility. So high risk pregnancies definitely come. Remember, it's 3 or more than 3 spontaneous abortions. Then what is the indicator of maternal health? So here we have just done the very basic of, what has to be done in antenatal period and how many visits are to be made, what are the things we are doing in PNC period, okay, nutritional, dietary recommendation, all those things, vaccination. Now, which is an indicator of maternal health, everybody? So maternal mortality is the indicator. Now, if you remember, this is a very favorite PYQ in exams. Okay, we talk as maternal mortality rate. Okay, this is what maternal mortality. It can be ratio or maternal mortality rate. Okay. Now, what is maternal mortality ratio? If I ask you, definition definitely comes ratio. What was in ratio? Numerator cannot be a part of denominator. So, this is what? Number of maternal deaths. Now, what did I teach you? Maternal mortality is the only place where the multiplier in entire community medicine, where the multiplier is 1 lakh. So, number of maternal deaths per 1 lakh live births. Now, can you see numerator is not a part of denominator? But if I asked you maternal mortality rate, what is it? Now, numerator has to be a part of denominator. So, per 1 lakh women in which age group? Reproductive age group. And what is this age group? 15 to 49 years. So can you see in ratio, numerator is not a part of denominator. Denominator is live birth. But in rate, numerator is a part of denominator. Denominator is reproductive age group. And maternal mortality is the only place, everybody, where we are doing a multiplication with 1 lakh. Now you would ask me, ma'am, what is maternal death? So as we have done earlier also, what is maternal death? What do you call maternal death? So maternal death, everybody, is the death during antenatal period, okay, or the death that occurs during delivery or postnatal period. Postnatal period means up to 42 days post-delivery. Okay, up to 42 days, or you could also say death up to 6 weeks post-delivery. But remember, it excludes accidental / which causes? Accidental / incidental causes. Okay, it excludes this. What do I mean by this? Give me an example. A pregnant woman, okay, if a pregnant woman slips in washroom, okay, will you count it as a slips in washroom and dies? Will you count it as a maternal death? No, this is no maternal death. Okay, this is not a death, maternal death. It will not be counted in that. Or suffers from an electrocution shock. Okay, electrocution shock ho gaya. Will you call it as a maternal death? No. Again, it is not a maternal death. Okay, so will you remember rate and ratio? Very, very important. Okay. All right. Current maternal mortality ratio is 97 per 1 lakh live births. Okay. All right. Now see, most sensitive indicator of delivery services under the healthcare India is maternal mortality ratio. What is the direct cause of maternal mortality? So the direct cause of maternal mortality, everybody, is hemorrhage. And what is the indirect cause of maternal mortality? It is nothing but anemia. Okay. Okay. These can come in your exam. So see, maternal mortality ratio. Now, can numerator be a part of denominator over here? Can it be? Numerator part of denominator in ratio? No. So multiplier has to be 1 lakh and maternal deaths per 1 lakh live births. Okay? Now let us talk about preventive pediatrics. Okay, so in preventive pediatrics also we have a lot of formulas which are very, very important, guys. That is what we are going to first focus on. Like, look over here, since I've put down the most important formulas for you, the first thing that you have to note over here is that everywhere the multiplier is 1000, guys. Okay, like in maternal mortality, that's the only place where the multiplier is 1 lakh. Okay, here it is what? The multiplier is 1000. So if you see infant mortality rate, number of infants death during the year per 1000 number of live births, everywhere the denominator is also live births, guys. And when I say infant death, it means from birth till 1 year, 0 to 1 year. Okay, what is neonatal mortality rate? It is the number of infant deaths up to 28 days. So it's saying number of infant deaths, but actually infant means 0 to 1 year. But when we talk about neonatal deaths, we are saying that it is infant's death up to less than 29 days, meaning 0 to 28 days. But multiplier is 1000 and denominator is live birth. Early neonatal death means death in the first 7 days of life. Okay, 0 to 7 days. Okay, so number of infant deaths within 0 to 7 days. Denominator again live birth, multiplier 1000. What is late neonatal? Late neonatal means from 8th day onward. Okay, it is from 8 days. So late up to first 7 days is early. So this is from 8 to 28 days. But again multiplier 1000, denominator live birth. Post neonatal means after neonate period, meaning from 29 days to 1 year. Okay, 29 days to how many years? 1 year. Okay, per 1000 again live birth. So everywhere the multiplier is 1000 and denominator is live birth. Okay. One more thing, remember, under 5 mortality rate is the same as child mortality rate. So this is death of a child 0 to 5 years. Don't get confused in child. It is not 1 to 4 or 1 to 5. It is 0 to 5 years. Okay, per 1000 live birth. And what do you mean by child death rate, guys? What do you mean by child death rate? Whenever you say death rate, what have I taught you? Like whether it's crude death rate or something, the denominator is always mid-year population. So denominator would be mid-year population and death rate mein kya ho jayega? Number of deaths 1 to 4 years of age. Okay, multiplier again per 1000, mid-year population in this range only. Okay, 1 to 4 years. Is it clear? That is what is child death rate. Okay, it is number of death which is 1 to 4 years of age per 1000, mid-year population between 1 to 4 years of age. Okay, so this is important. What did you see? That in pediatrics, everywhere the multiplier is 1000, denominator so far is live births. Okay, infant mortality rate में death is 0 to 1 year. Neonatal mortality rate में death is 0 to 28 days. Early neonatal mortality rate is 0 to 7 days. Late neonatal mortality rate, everybody, is 7 to 28 days. Post neonatal mortality rate is from 29 days till 1 year. Okay, and under 5 mortality rate, if I ask you, under 5 is child mortality, so 0 to 5 year. But everywhere multiplier 1000, denominator live birth. Only for death rate, the denominator is mid-year population. Now, there's also a term perinatal mortality rate and stillbirth rate. What is perinatal? So, perinatal is an indicator, perinatal mortality rate is an indicator which is reflecting both the antenatal period as well as after birth. Okay, so it is late fetal death plus early neonatal death. Late fetal death means beyond 28 weeks gestation. Okay, plus early neonatal death means first 7 days of life. Multiplier same है, per 1000, denominator same है. But what is stillbirth? It is just late fetal death, okay, or number of stillbirths per thousand. The denominator for the first time is total number. See, ideally India या किसी भी developing country में for stillbirth rate the denominator becomes total number of births, okay. But developed countries, it is live birth only. Now, what do I mean by late fetal death, guys? Remember, it is death, it fulfills certain criteria. Death beyond or equal to 28 weeks gestation. If this is not mentioned, then at least weight of the baby is mentioned. Okay, so that is 1 kg or 1000 grams. Otherwise, length of the baby we must say 35 centimeters. You know, the average length of a newborn is 50 centimeters. In stillbirth, we say it should, to call it as a stillbirth, at least the length of the baby should be 35 centimeters, weight should be 1 kg, and the period of gestation should be 28 weeks and above. Okay? So that is very, very important thing which can come in your exams. All right, then what do you have over here? Most common cause. Okay, now remember one thing. If I ask you what is the most common cause of neonatal mortality rate, infant mortality rate, under 5 mortality rate, for all it is low birth weight or prematurity. That's what your textbook of Park also mentions. And there was a cause of death survey which was done. Okay, cause of death survey, okay, which was done for 2017 to 2019. The data got published by SRS in 2023 February. Okay, according to that, it is this low birth weight and prematurity. But I would also like to tell you something. So there was one more survey, medical certification cause of death survey. Okay, cause of death survey, which was done in 2019. According to that, the most common cause of neonatal infant under 5 mortality became asphyxia, birth asphyxia, all right, or hypoxia. Okay, medical certification of cause of death survey of 2019. But as per the latest data which got published, it is still low birth weight or prematurity. So I'm just telling you so that when you see in the question, okay, if it mentions some survey like MCCD survey, okay, then only the answer will change. Otherwise, it's the same. Okay, and child death rate ke liye in developing countries, the most common cause is diarrhea. Okay, this is a PYQ. What is child survival index? Okay, this is proportion of children who are going to survive till age of 5 years. Okay, this formula is asked 1000 minus under 5 mortality rate divided by 10. All right, everybody. Okay, then they also ask you just like at-risk pregnancy, at-risk infants. Birth weight less than 2.55 because that is low birth weight. Twins, birth order 5 or more. Spontaneous abortion 3 or more was high risk pregnancy. Birth order 5 or more. Infants on artificial feeding. Second and third degree malnutrition. Second, third matlab technically the weight is less than 70% of expected weight. Then failure to gain weight in 3 successive months. So this is known as what? Failure to gain weight in 3 successive months is known as failure to thrive. Child with PM diarrhea, babies of working mother and single parent are at risk infants. Okay, obviously people do work, they should go to work, but then theoretically it's definitely putting the baby at risk. Okay, all right. Now, considered by UNICEF as the best single indicator of social development and well-being of entire society is under 5 mortality rate, or you would also call it as child mortality rate. Okay, this is considered by UNICEF. But look over here. Okay, now look at some key points. Most common cause of neonatal mortality, low birth weight or prematurity. Most common cause of infant mortality, low birth weight / prematurity. Same thing. Under 5 also same thing. Best indicator of health status of a population, guys, IMR. Utilization of services, health status, everything IMR. Okay, best indicator of health status and socioeconomic status, okay, according to this is under 5 mortality rate. Best indicator of combined pediatrics and obs care, that means when the baby is in the womb and when the baby has come after. So perinatal. Okay, PMR. Why perinatal? Because it's death beyond 28 weeks of gestation plus first 7 days of life. So perinatal mortality rate. Best indicator for healthcare delivery services in a population. Please remember, healthcare delivery services in a population is maternal mortality ratio. Okay, that is again very important. And in case they ask you best indicator for health status of a population and also utilization of services. Okay, so what is this, everybody? This again is IMR. Okay. Now what is low birth weight baby? You all know 2.5 kg se niche, right? Average birth weight of Indian babies, how much is it? Average birth weight of a Indian baby is, please remember, 2.8 kg, and low birth weight is below 2.5 kg. All right, small for date baby is birth weight less than 10th percentile for gestational age. This is also a PYQ. All right, now they can be born at term or preterm also, but the weight is, there's intrauterine growth retardation. All right, and they have poor prognosis. Okay, they have poor prognosis than a preterm baby. Okay, so small for date babies may be born at term or preterm. They have high risk of death. What is preterm? Preterm is less than 37 weeks. Term is 37 to 42 weeks. And what is postterm, everybody? More than 42 weeks. All right, now for growth and development, which is the best indicator which is going to reflect the growth? We are always taking weight for age. Okay, now remember one thing, like I told you, weight of a baby, okay, at birth, guys, in India the average is 2.8 kg. When does the baby weight double? This is again an MCQ. Weight doubles at 5 months, right? When does the baby weight triple? So weight triples at 1 year. And when does the weight quadruple, guys? So the quadrupling of the weight is by 2 years. So accordingly you can assess malnutrition. Okay, so around 2 years 11 to 11.2 kg baby ka weight hona chahiye. All right, what about height? And weight is kind of reflecting, if you just say, acute status. Okay, but height is something which reflects chronic status, long standing one. Okay, the average length of a baby is, please remember, of a baby born is 50 centimeter, and the length, or after 2 years we say the height. So when does the length of the baby double? By 3 to 4 years. Okay. Indicators for growth and development, we have acute malnutrition, chronic, acute on chronic. Very, very important. Never say acute is low weight for age. No, acute is low weight for height, guys. Okay, this is also known as emaciation / wasting. Okay, low weight for height. But what is chronic malnutrition? Chronic is long standing, so low height for age, and this is what? This is reflecting stunting. Acute on chronic means you're chronically malnourished. On that, acute is superimposed. This is low weight for age, which is most commonly being used to assess malnutrition status. Okay. See, weight for age is a general marker, most sensitive marker for malnutrition. Weight for age is the one which is being plotted in growth charts also up to 5 years. Okay, not beyond 5 years. Beyond 5 years, we prefer to take BMI. All right, so this is something. Now look at this image, can come Salter scale. So this is used to measure weight of baby at field level. Okay, then this is infantometer. This can measure the length of baby up to which year? Length of baby up to, now this is infantometer, not just infant, up to 2 years, guys. And after 2 years, we measure the height. So that is measured by a stadiometer. Okay, it measures height beyond 2 years. All right, some of the instruments. Now, very, very important thing which you have to study and revise in rapid revision also is the growth charts. ये कौन सा growth chart है? ICDS, the one which is recommended by ICDS. All right, and this is for girls. Pink color is for girls, and if it was blue color, we all know it is for boys. Now, always remember, growth charts are being used by, they are color coded. So, they are of importance to the health workers, okay, to assess malnutrition status, okay, to assess malnutrition status. They are particularly being used at the ICDS centers. Anganwadi workers are using them. Now, remember, ICDS growth chart was adopted from whom? ICDS growth chart was adopted from WHO growth charts, guys. So first let us make the WHO growth chart. Now, WHO growth chart has only 2 lines. And what are you plotting? This is the x-axis, y-axis. In this, always you're going to plot age. Age will be plotted completely in years as well as months. And on the y-axis, we are going to plot the weight. So, in this WHO growth chart, it has 2 lines. This is the first line. Isko bolte hain URC. What is URC? Upper reference curve. Okay, this corresponds to what? 50th percentile for boys. And this is the LRC. What is LRC? Lower reference curve. What does this correspond to? Always corresponds to 3rd percentile for girls. Now, if any child is between this upper reference curve and lower reference curve, this is what? The green zone. Green zone indicates road to health, means the growth of the child is adequate. But if he is below this, all right, this is an area of yellow to red. Basically, here we have 2 lines. So, this below this is just an indicator of, it could be, that means baby is malnourished, mild, moderate, severe. So, WHO growth chart has only 2 lines. And remember one thing, WHO growth chart, everybody, WHO growth chart is based on what? MGRS standards. What is MGRS standards, guys? It is actually a multi-centric growth reference study. It was conducted in 6 countries, out of which India was also a part. Now, if you look at ICDS growth chart, okay, this ICDS growth chart is going to have 3 lines like this. Okay, this is the first line, this is upper reference curve, okay, but this is 0 over here. This is the second line, lower reference curve. This corresponds to -2 SD, and the line below that corresponds to -3. Or agar koi line iske upar hai, there's a line above this. This is +2 SD. So any child basically between +2 to -2 is belonging to the green zone. Okay, or you could here, just for your reference, remember from 0 to -2. Okay, this is the green zone, which reflects what? The green zone reflects road to health. Okay, you don't have to worry, the child's growth is adequate. But if any child is between -2 SD to -3 SD, ये वाला zone. Okay, what is this? This is nothing but mild to moderate malnutrition. Okay, what is this? Mild to moderate malnutrition. And in case a child is below -3 SD, okay, below -3 SD, this is which zone? Red zone. So this is severe malnutrition. Here again you have age, here again you have weight. Always remember, growth charts we are plotting weight for age. Okay, so this one over here below -3 SD is which zone? Severe malnutrition. Ab karoge kya? Alright, so if somebody is in the green zone, you don't have to worry. Mild to moderate malnutrition, we can rely on home management. Okay, that means what? A medical officer at a PHC can look after the child and send back home and accordingly advise the mother. In red zone, the child has to be referred to at least a CHC where there is a pediatrician. Okay? So, in yellow zone can be managed at home after medical officer sees, but immediate referral to a CHC will be needed in red zone. Okay? So remember, growth charts are used to assess malnutrition status in ICDS. This thing we are plotting weight for age. It has been adopted up to 0 to 5 years. It has been adopted from WHO growth charts. And ICDS growth chart, everybody, ICDS growth charts are going to have 3 lines like this. Okay, this is very, very important. Then you have another thing, Charcot's tape. Okay, this is also used to assess malnutrition status at which level? This can also assess malnutrition status, everybody, at field levels. Okay, so it can be used by healthcare workers to assess the malnutrition status. If you remember, this is an example of appropriate, okay, this is an example of appropriate technology, everybody, one of the principles of primary health care. Now it has 3 zones, red, yellow and green. Red again is below 11.5, SAM child, okay, severely malnourished. 11.5 say 12.5 is now undernourished, and more than 12.5 is normal. So if any of this the health worker sees, immediately she will, in the field, she will immediately refer to an ICDS center, and accordingly management will be done. Now always remember, what is these images? They are very, very famous PYQ. These are manifestations of a SAM child. Now when do you call someone a SAM child? Severe acute malnutrition child. So like we said, you have to take acute. So weight for height is below -3 ST. Okay, and or mid upper arm circumference. Okay, so here you can see the cutoff 11.5. So mid upper arm circumference less than 11.5 centimeters or 115 millimeters. Again, and or bilateral edema. SAM child बोलेंगे. This image that you see, this is manifestation of SAM child. This with the protruding belly, this is what? Kwashiorkor. Okay, and this where the ribs and old age appearance type, this is what? Marasmus baby. So a lot of questions come from this. Kwashiorkor and marasmus are manifestations of SAM. Okay? So what is the question which is asked is the difference. So look over here. This is very, very important. Kwashiorkor develops in children whose diets are deficient of protein. Marasmus, both proteins and calories. Okay. It occurs in children between 6 months and 3 years. Kwashiorkor. Marasmus is under 1 year of age. Subcutaneous fat is preserved. Marasmus, it is not preserved. Like you can see, there's a protruding belly. Edema is present in Kwashiorkor. Liver enlargement ho jata hai. Involvement in Kwashiorkor. Marasmus edema is absent. Okay, ribs are not very prominent, they become prominent. Kwashiorkor baby, see, look at the baby, appears all fat kind of, but it's not actually that. It's the enlarged liver and all that, okay, which is responsible for that. So the baby has become extremely lethargic. Marasmic baby is alert and irritable, okay, and Kwashiorkor baby has a very poor appetite. Marasmus is a voracious feeder. Muscle wasting mild or absent. Marasmus, there's severe muscle wasting. So when a person is suffering from Kwashiorkor, you have to feed him a large amount of adequate amount of protein. For marasmic baby, we have to give him all protein, fat and carbohydrates because even calories are deficient. Okay, so this is very important. Which is more common, guys? If anybody asks you which is more common, it is marasmus. Okay, but if somebody asks you which is more severe with poor prognosis, ठीक है, more severe क्या है? More severe तुम्हारा Kwashiorkor है. Got it? So this is important. Now, a few points quickly about breastfeeding. Exclusive breastfeeding should be done up to 6 months. We all know. Can be continued up to 2 years. And when should breastfeeding be initiated? It should be initiated as soon as possible after delivery. There's no guideline. Okay, that 1 hour, 3 hour, no. Whether vaginal C-section, as soon as possible you give. Energy 65 kilocalories per gram, protein 0.9 to 1.1 gram. Now remember, human milk, breast milk has the maximum amount of lactose. Alright, it might have like cow's milk, usme 67 kilocalories hota hai. But human milk has 65. But although it might have less iron, calcium, the bioavailability of all that is much more. Alright, immunoglobulin, which is most abundantly secreted, is IgA. It is rich in immunoglobulin. Colostrum, you should never discard it because see, early 3 days is not that fatty milk, but it is having something which is very important, docosahexaenoic acid, required for brain development and myelination. Vitamins deficient is vitamin D and K. D is present in small amounts, okay, but then we need to put the baby in sunlight for some time. Cow's milk, amino acid present for brain development, everybody is taurine. Cow's milk is higher in protein energy content and fat content, cow's milk versus human milk. Human milk, remember, has higher lactose, iron, water and calcium phosphorus ratio, and it has better casein weight ratio of 40:60. Okay, the bioavailability is more. Although the fat, the protein, the energy, everything is more in buffalo than cow, than breast milk. But breast milk is easily digestible. Okay, it can easily be digested by the babies. All right. School health concept may you just have to remember a few points. Concept was given by Bohr committee. Okay. It was improvised by whom? Renuka Roy committee. She said that school health checkup should be done once every 4 years, but according to current guidelines, okay, according to current guidelines, guys, now the school health checkup is done once every 6 months. You must know certain points, okay, when you have to talk about school health. Detailing you can see from the main lecture, but certain things which are important is that one classroom can accommodate up to 40 students. Okay, all right. One urinal is present for 60 students. One latrine for 100 students. Okay. Desks provided should be minus type. Desks should be minus type. Per capita space available per student should be more than 10 square feet. Okay. Light should come from, most of us are right-handed, so light should come from the left side. These are certain bare minimum things that you should know for school health services. Door and windows should occupy more than 25% of floor area. Okay. Most common school ailment, okay, or most common infection which is reported, okay, from schools, okay, examination, please remember, is dental ailments, okay, dental infections you can say. Okay, that is the most common infection which is reported. Then here I would also like to tell you there is a school eye checkup program, okay, school vision screening, okay, you could say vision screening. These are all secondary level of preventions. So that can also be done by a teacher, one teacher up to 150 students. And if the visual acuity is less than 6/9, the child is referred to a PHC where we will have a paramedical ophthalmic assistant who will refer the child, if required, prescribe him glasses or refer further to a ophthalmologist. Okay, these are the bare minimum things that you must know for school health checkup. Please remember, school health checkup is an example of, it's a checkup, so it's an example of secondary level of prevention. Now some MCQs. Perinatal mortality is death within first week of life, abortion, stillbirths, death within first week, death from 28 weeks to first week of life. Stillbirth is death of a fetus weighing 1000 gram or more in 1 year per 1000 total births. I told you stillbirth rate में ही total births आता है. At risk infant except birth weight less than 2.8. No, 2.8 is the average. It is less than 2.5. Like working mother is at risk infant ka this thing. Mean birth weight of Indian babies we all know is 2.8 kg. Low birth weight is defined as birth weight below this. Birth weight less than 10th percentile is small for date babies. So that's it. Okay, this is an important chapter. Remember one thing. Whenever you get maternal mortality, multiplier 1 lakh. For every other thing, multiplier 1000, denominator life birth. Okay, only in stillbirth, the denominator becomes 1000. Okay, most common causes can easily come, and growth charts. Don't forget to revise them. Thank you so much.